Welcome guys. Today's lesson is about cellulitis, erysipelas and necrotizing fasciitis. Soft tissue infection encompass a variety of pathological conditions that involve the skin and the underlying subcutaneous tissue, fascia or muscles. The principal determinants for soft tissue infections is whether it is non-necrotizing or necrotizing infection, or whether it is purulent or non-purulent. Necrotizing soft tissue infections are characterized by rapidly advancing local tissue destruction and systemic toxicity, including shock. Tissue necrosis distinguishes this necrotizing soft tissue infection from cellulitis. In cellulitis, an inflammatory infectious process involves subcutaneous tissue but does not destroy it. To start from cellulitis, cellulitis is an infection of the dermis and subcutaneous tissue that has a poorly demarcated borders, and it is usually caused by Streptococcus or Staph aureus. A break in the skin from previous trauma, surgery, or an underlying skin lesion predisposed to cellulitis. Cellulitis is also more common in individuals with lymphatic status, diabetes, and or other immunosuppression medications or disease. It is always unilateral, and most of the time lower extremity is mostly affected. As you see on the image, cellulitis manifests clinically as a localized area of edema, worms, erythema, and tenderness. The lateral margins tend to be indistinct because the process is deep in the skin, primarily involving the subcutaneous tissue in addition to the dermis. Application of pressure might produce pitting in some cases of cellulitis. Regional adenopathy and the constitutional signs and symptoms such as fever, chills, and malaise are common. When we see complications of cellulitis, cellulitis can cause subcutaneous abscess. It can complicate as bacteremia, osteomyelitis, septic arteritis, thrombophlebitis, endocarditis, and necrotizing fasciitis. Lymphangitis or glomerulonephritis can also follow infection with Streptococcus pyogenes. Cellulitis is diagnosed clinically, and blood culture should be considered if the patient is younger than 1 year of age, or if there is signs of systemic toxicity, and if there is an adequate examination cannot be carried out, or an immunocompromising condition such as malignancy, neutropenia, or other things are there. Aspirates from the site of inflammation, skin biopsy, and blood culture allow identification of the causal organism in approximately 25% of cases of cellulitis. Yield of the causative organism is approximately 30% when the site of origin of cellulitis is apparent, such as an abrasion or ulcer. Ultrasonography can be performed if an associated subcutaneous abscess is suspected. Once we diagnose cellulitis, empirical antibiotic therapy for cellulitis and the initial route of administration should be guided by the age and the immune status of the patient, history of the illness, and the location and the severity of the cellulitis. Infant and the children older than 2 months with signs of systemic infection, including fever, lymphadenopathy, or constitutional signs, also require hospitalization and the treatment with intravenous antibiotic effective against streptopyogenes and the Staph aureus, such as clindamycin or at least first generation of cephalosporin. Overall, when we see treatment of non-purulent cellulitis, we can classify it as mild, moderate, and severe. For mild one, pure antibiotics is enough, which covers strep pneumonia and the Staph aureus. And for moderate one, we should have to consider IV antibiotics, and for severe one, we should have to give antibiotics that covers MRSA, such as vancomycin. Once the erythema, worms, edema, and the fever have decreased significantly, a 5 to 7 day total course of treatment might be completed on the outpatient basis. Though treatment should be extended if the infection has not substantially improved with this time period. Elevation of an affected limb, particularly early in the course of the therapy, might help reduce swelling and the pain. And if present, a subcutaneous abscess should be drained. The second one is erysipelas. Erysipelas is a superficial form of cellulitis, and it affects the upper dermis and extends into the superficial cutaneous lymphatics. Erysipelas most often affects infants and older people, but can affect any age group. And risk factors are similar to those for other forms of soft tissue infection. When we see the main difference between cellulitis and erysipelas, in cellulitis, the infection involves the deeper dermis and adjacent subcutaneous tissue, whereas in erysipelas, it refers to superficial infection involving the upper dermis and the superficial lymphatics with more clearly demarcated borders. So erysipelas is superficial and it is a well demarcated infection, whereas cellulitis is a more deeper infection and it is border and its edge is not well demarcated. Regarding etiology and the clinical manifestation, unlike cellulitis, almost all erysipelas is caused by group A beta hemolytic streptococcus. Signs and symptoms are abrupt in onset and often accompanied by fevers, chills, and shivering. Erysipelas predominantly affects the skin of the lower limbs, but when it involves the face, it can have a characteristic butterfly distribution on the cheeks and across the bridge of the nose. The affected skin has a very sharp and raised border because the infection is superficial. It is a bright red, firm and swollen, and it might finally dimpled and like an orange skin. It might also blister, and in severe cases it might become necrotic. Regarding treatment of erysipelas, the general treatment is by cold packs and analgesics to relieve local discomfort, elevation of unaffected limb to reduce local swelling, compression stocking, and wound care with saline dressings that are frequently changed. And regarding antibiotics, oral or intravenous penicillin is the antibiotic of first choice, and vancomycin is used for fascial erysipelas, which might be caused by methicillin-resistant Staph aureus, and the treatment is usually for 10 to 14 days. The third one is about necrotizing fasciitis. Necrotizing fasciitis is a subcutaneous tissue infection that involves the deeper layer of the superficial fascia, but it might spare adjacent epidermis, deep fascia, and the muscle. Most cases of necrotizing fasciitis are polymicrobial, which is called synergistic necrotizing fasciitis, with an average of 4 different organisms isolated. The organisms most commonly isolated in polymicrobial necrotizing fasciitis are Staph aureus, streptococcal species, Klebsiella, E. coli, and the anaerobic bacteria. This is an image of necrotizing fasciitis on the hand of a patient. The rest of the cases and the most fulminant infections associated with toxic shock syndrome and the high case fatality rate are usually caused by group A streptococcus or S. pyogenes. Infections caused by any organisms or combination of organisms cannot be distinguished clinically from one another, although development of crepitus signals the presence of gas-forming organisms such as Clostridium or gram-negative bacilli such as E. coli, Klebsiella, and protease. When we see the clinical manifestation of necrotizing fasciitis, which can occur anywhere on the body, and the polymicrobial infections tend to occur on perineal and the trunk areas, and the incidence of necrotizing fasciitis is highest in hosts with systemic or local tissue immunocompromised. The infection can also occur in healthy individuals after minor puncture wounds, abrasions, or lacerations. This is clinical features of necrotizing fasciitis based on the stage, whether it is early, intermediate, or late. Earlier, tenderness to palpation, erythema, swelling, and the color change is the most common manifestation. And lately, crepitus, skin anesthesia, skin necrosis with dusky discoloration, tissue necrosis progressing to gangrene can occur. Definitive diagnosis of necrotizing fasciitis is made by surgical exploration, which should be undertaken as soon as the diagnosis is suspected. Necrotic fascia and the subcutaneous tissue are gray and offer little resistance to blunt probing. Although CT and MRI aid in delineating the extent and the tissue planes of involvement, this procedure should not delay surgical intervention. Frozen section incisional biopsy specimen obtained early in the course of the infection can aid management by decreasing the time to diagnose and helping to establish the margins of involvement. Gram staining of tissue can be particularly useful if chains of gram-positive cocci indicative of infection with S. pyogenes are seen. Treatment-wise, early supportive care, surgical debridement, and the parenteral antibiotic administration are mandatory for necrotizing fasciitis. All devitalized tissue should be removed to freely bleeding edges, and a repeated exploration is generally indicated within 24 to 36 hours to confirm that no necrotic tissue remains. This procedure may need to be repeated on several occasions until devitalized tissue has cased to form. Meticulous daily wound care is also very important. Parenteral antibiotic therapy should be initiated as soon as possible with broad-spectrum agents against all potential pathogens. Initial empirical therapy should be instituted with vancomycin, linezolide, or daptomycin to cover gram-positive organisms and piperacillin tazobactam to cover gram-negative organisms. An alternative is to add ceftriaxone with metronidazole to cover mixed anaerobic and aerobic organisms. Definitive therapy should then be based on sensitivity of isolated organism, and penicillin with clindamycin is indicated for necrotizing fasciitis caused by either group A streptococcus or Clostridia. For group A streptococcus infection, clindamycin is administered until the patient is hemodynamically stable and no longer requires surgical debridement. Antibiotics are generally continued for at least 5 days after signs and symptoms of local signs and symptoms have resolved, and the typical duration of therapy is 4 weeks. When we see the prognosis of necrotizing fasciitis, the combined case fatality rate among children and adults with necrotizing fasciitis and syndrome due to polymicrobial infection or S. pathogen has been as high as 60%. However, relatively death is less common in children and in cases not complicated by toxic shock-like syndrome. This is all about what I have regarding soft tissue infection. Thank you for watching.